they'll say that as well. I'm not trying to disparage anyone. It's a complicated issue, and they're listening to all the wrong voices. So having groups like this come together and garner together and lifting each other up, it's really important. But, you know, I get asked a lot, David, is healthcare irreparable? And most days I want to say yes, absolutely it is. And even right now I might say, in the current system that it functions in, perhaps. However, what many of you in this room are doing is not functioning within the current system. We're running in parallel. You're doing something new. You're doing something unique. And I want to take this time now to honor a lot of you that are doing these unique things. If you're a primary care physician, I'm going to ask you to stand up, please. Are there any specialists in the room? Already standing. Laboratory providers. Imaging providers. Thank you. How about telemedicine? Surgery centers. Anybody dealing with surgery centers or owning surgery centers? There he is in the back. How about emergency departments? Same guy. Hospitals. I know one of our sponsors. Give somebody else a chance. Third-party organizations, Lasso Health, Free to Care, which I'm representing them as well. You got to stand up. Brokers in the room. On your feet, guys. Employers. Did I miss anybody? Nurses. Medical professionals. And lastly, patients. If you're a patient, stand up for me. You should have stood up at the very first, Dr. Robinson. I don't care that you're retired. Guys, thank you. You are the change makers. Everybody standing in this room are the folks that can make a difference, and I encourage you. Have a seat. Thank you for standing up. Thank you for entertaining me. What do all of you have in common? Ultimately, we're all patients, right? But I don't mean those who are consumers of healthcare. What do the people in this room have in common? People would say, well, they have a greater tolerance for risk. They're not comfortable with the status quo. I want to say it a different way. You're brave. The folks that no, there we are. The entities that function in the current status quo of this country, and I'm not going to point at organizations that may be in the next room. You know, they're here celebrating their excesses. We're here because we want to make their parties less elaborate. It's important. It's important for us to be brave and to convey that bravery to other people, because organizations that are currently in the status quo use fear as their primary tactic. We hear that from patients. We hear that from insurers. We hear it from a lot of employers that are not willing to really make that jump, and oftentimes for a lot of good reasons. But we're going to hear from employers today is why they made the difference, why they made the changes that they made. I heard from an organization that is going through, they're changing from a Blue Cross to another organization, and then they said, you know, having a Blue Cross card is like having a warm blanket wrapped around you. It just makes you feel good. And I said, yeah, but the blanket's dirty and it's infected with smallpox, and Blue Cross won't even cover that. So I'll stop. I'll end with a quote that I want to share with you. And many of you have probably heard it before. Isaac Newton had written this, and he says, "If I've seen further than others, it is by standing upon the shoulders of giants." Ladies and gentlemen, you are those giants. Steady your shoulders, because the work that we're doing today is going to be important for the next generation, for the people that will see what you do and say, if they can do it, we can do it too. So you are purveyors of hope. Understand that, know that, embrace it, and share it with others. Be infectious. And so I'll end it with that, but I would love to have any conversations with you afterwards. But you know, the group here is going to have a lot of this content after this meeting on social media. Send it to everybody you know. There's going to be a lot of good discussion. There's going to be a lot of great points that are going to be made. And most of all, the thing that's most compelling are the stories that you're about to hear. So Dr. Mochigemba and the panelists, we look forward to having you up here. We look forward to hearing what you have to say and the stories that you're going to tell us that will give us more hope. Thank you guys very much.
All right, let me see if this will fix it. Okay, no, does it? Does it? Yeah, that sounds better. Okay, all right, that's a good step forward. Dr. Roger, you can take this microphone and get started on the introduction to the panel, and then the panel will have to use the other microphone.
Okay, so I'm Dr. Mochigemba. Everybody just calls me Dr. Roger. Can everybody hear me okay? Okay, so I want to thank Shankar so much. You can see he's doing so much work here. There's a lot of work that goes on behind the scenes. I can't thank him enough. He is my co-sponsor of the San Antonio chapter of the Free Market Medical Association. Before I introduce the panelists, I just want to thank everybody for coming and let everybody know that this is a really special night for me, because for the last few years, Shankar and I have been building this San Antonio chapter of the FMMA, and tonight is a historic night here in San Antonio as far as I know, because for the first time in San Antonio, we have representation from the whole healthcare continuum, from primary care to tertiary care, that is direct pay and transparent. David introduced all of those constituents here. So this is a great night, and hopefully it's just the beginning of more. With everybody's help here, we can continue to build this momentum. I was thinking about this night for the last few days, and I shared this with a couple of people, but actually from the people that are in this room, from the employers to the clinicians to the brokers and even the telemedicine folks and the Lasso folks, with all of the work that we're doing, right now, the people in this room, we are literally providing affordable access to care to thousands of people. And that's one of the things that drives me and Shankar and a lot of you in this room. So with that, we'll go ahead and get started. Our panelists today, I'm so thankful to have Bill Cox here. He's the owner of Cox Manufacturing, which is Bill Cox is a leader in the manufacturing industry. He's been part of the San Antonio Manufacturers Association, which represents a lot of manufacturers in this area, and I think he's also involved on a national level with the manufacturing associations. So we're so pleased to have him on the panel. If you want to take a seat up at the table. And then we have Janice Martinez here, who I'm so happy to meet a couple of months ago at the Free to Care conference in Austin. Janice is the head of HR at Texas Disposal Systems, and that's an employer that represents employees all over the state. And then we have Dr. Cliff Porter here. He is a good friend and colleague who is a direct primary care doctor who has a couple of locations in Austin and Buda. So the way that we'll do this is I'll be the moderator, and I hope to just start a discussion, and we'll talk about the employer's journey to affordable care. We'll have a few questions and discussion, and then towards the end, we'll open it up for some questions from the audience, okay? So running a successful business requires a lot, and it takes a lot of your attention. So this first question has a couple of components. First of all, running a business is pretty complex and takes a lot of your time. So first part of the question is, why would an employer even be concerned with providing affordable access to care? And then the other part of the question is, what was the status of the benefit program in your company when you were exposed to direct care, and how did that get your attention? Let's see, Bill, do you want to start with that one?
So it may be worth kind of rewinding to get some perspective. If I go back a few decades, I was at a seminar in 1992 in Detroit. There was Ford Motors that put on a presentation. A consultant that some of you may have heard of, if you're in the manufacturing circle, you would have for sure, Edwards Deming. He was a guy that Ford Motors hired when he was in his 80s to teach them how to do quality better to compete with the Japanese. So he had been working, he was an American statistician that went and worked in Japan for years to improve their quality. He came to the United States, he worked with Plymouth, and he was working with Ford as a consultant. I didn't even know if he was going to speak at the conference, but it was a one-week conference. And he's 92 years old, actually. He was born in 1900, and they wheeled him up on a chair. And some of his YouTube videos or films of his presentations are still out there. Anyway, end of the conference, 1992, someone asked the question in the Q&A. They say, "What do you see for the future of American health, of American manufacturing?" And he pauses. He's 92, right? And he says, "My biggest concern is your runaway health care cost." He had already seen that Plymouth was spending more money on health care than steel in our automobiles, and that definitely was different than Japan. And I mean, if I look back, at the time it didn't really hit me hard. It was kind of like, that was, we're all there to think about quality and how to improve our management systems. In 1992, he's already worried about our runaway healthcare costs. So in perspective, what we have is a system that we've put in place that we haven't changed since 92, and it's a runaway train, and it's unsustainable, and we've created a system that is not subject to the normal economic force that's normally in a capitalistic system. And we've got to break that chain. And the insurance system where the employer just passes on money, whatever the increase is, they share it with the employees and divide it up. It's just growing and growing and taking a bigger and bigger bite out of our employees' budget. And it's crazy how high it is now. It's shocking. There's other facets to it. Now there's the wellness component. The health of the American population is just alarming. With the generations we're raising now have got a lower life than the prior generations. in the system. So there's the inputs, the health of our population. There's the capitalistic leeches that have created a system to suck money out and create their own wealth mechanism. And then there's the employer in the middle. So I started looking for solutions a number of years ago. Almost 10 years ago, we started doing wellness programs internally. We started off doing them just on a voluntary basis. We'd sponsor a lunch and invite employees, and we've gone through several iterations of that. But we tried to educate the people first. Then my journey has been, and maybe I'm going further on my question, going above and beyond answering the question. So my journey has been to first educate the people, and then to move. We wanted to get the employees to start looking at the cost where people were more in touch with the money they were spending, to start asking questions. We've gone to a self-funded plan, and now the DPC, the direct primary care model, which so instead of paying for sick care, the idea is to pay for health care. And it's just the beginning of a battle. We've got a long ways to go. But the deck's been stacked against us, and this train has been moving for a long time, folks.
So thank you, Bill. So I think what we've seen is that an employer, an old-timer, giving some advice to new business owners coming up in the system. The advice was taken, and then Bill started to try to put some things in place for his employees to take care of them, right? They're your assets in the business world, right? And so it was baby steps and an evolution, okay? So thank you for that. Janice.
I represent an organization that has about 1,200 employees throughout the state. And we have everything from laborers to attorneys and CPAs and everything in between. So the needs of our employees are pretty diverse. We have different generations, different socioeconomic levels, different professions. And so there wasn't any one solution that was going to work for everyone. The programs that were in place were very traditional. You know, you had your, and along comes a broker that was very visionary and really kind of thought outside the box. And so about 7 years ago, we started doing things like unbundling our services. Some of the different generations. If you have someone that is 60, their needs are going to be very different than that employee coming straight out of college. So we had to look at how our programs met the needs of our employees. We also had to look at cost. And so we really evaluated our spend. We also evaluated, you know, our biggest claims and what was bringing that about. And it typically is, you know, that 10% of the employees were spending 80% of the dollars. And so we looked at what were the commonalities, and let's address some of those things. So that moved the needle for us a little bit. Along comes COVID. And I don't know about y'all, but COVID has really made us look at things differently and do things differently. And what is it? We had to reinvent ourselves, so to speak. We couldn't do things the way we've always done them. And our owner comes one day and says, Janice, I want you to find a doctor that will be aggressive with COVID so that he can serve our employees. Well, I wasn't sure how I was going to do that. I didn't know how I was going to call a doctor and say, how do you treat COVID? Do you prescribe medications, hydrocodone? What do you do? And I got this email. I think it was an act of God because it was so timely. And it was from this guy, Dr. Porter, who is now on my side over here. Didn't know who Cliff Porter was, but he says, you know, I've got this program you might be interested in. I'm trying to build a clientele in this area. Would love to talk to you. And I thought, oh my gosh, I've got to find this doctor for our owner. And so I met with Dr. Porter, and I said, this is what I'm looking for. He says, I can take care of you. All right, let's do it. And as we got people that were sick, we send them to him. We paid all the expenses. We paid for families as well. We were trying to keep our employees healthy. The company I work for, Texas Disposal System, we are a waste management company. So we are considered an essential business. That means while everyone else was being sent home to work remotely, our trash trucks were still on the road. We don't close. We don't have that luxury, and we serve the community. If we closed our doors, that would have a really detrimental effect to the community and to the health of our community. So our people were working. We needed to keep them healthy. We needed to keep their families healthy. And so Dr. Porter says, well, this is a model I have. And at the time I said, you know, I think we're just going to pay for services a la carte, and we can talk later. Our owner really had a good experience in working with Dr. Porter and his clinics, and said, Janice, we've got to do something with him. So, you know, we have a new broker, very traditional, and I said, we want to develop a plan around this direct care method. And they're very resistant. I asked 5, 6, 7 times. I need for you to call him. I need for you to work out a program that we can fold into our traditional program. No response. I finally wrote it all out. I said, okay, I developed the program. Here it is. Make it happen. And so what we have to remember, and we have to have our employers remember, is we're the customers. We are the customers, not the insurance companies. It is the employers. It's our pocketbook, our employees' pocketbooks. And so we were able to bring together the best of all worlds. We kept the standard plan and premium plan for those employees that are most comfortable with that. But we have a choice for them. And we call that our dedicated doctor plan, or as everyone calls it, the Dr. Porter plan. And what we've done is for primary care, we have DPC. We have included in that, we've wrapped it with prescriptions and emergency care and specialist care. We've also made it worth the employee's while to try it. We're charging them base rates with premium level benefits, which means if they go to the hospital, their benefits are going to be just like if they were in the high plan, but they're paying the low premiums. We had to make it attractive to them, to let them feel like it was okay to take a risk, because it was uncomfortable. It was an unknown. And we just finished our first year. We're going into our second year. Our first year, we had about 15% of our employees that signed up. Not a single complaint. So I'm anticipating that we're going to grow this year. We just had a really exciting meeting in San Antonio, and we're partnering with Dr. Roger. I'm not going to try to say his name. I'll get it wrong. And so we're creating an alliance between Austin, San Antonio, and we hope that it'll grow from there. It's helping our employees. We are located in a very rural area. So if an employee has a doctor's appointment, it takes them half a day to get to their appointment, sit and wait for the doctor. I know they're all on time all the time, but sit and wait for their doctor and make it back. And for most of these employees, they do not make any money if they are not working. They're on incentive programs. So when they're sick, it takes a bite out of their pocketbook. So we had to create something that worked for them. So we transitioned that in. We have found it successful, and now we're growing our program.
Thank you so much for that. So it looks like what we've had is an employer, a large employer, with a traditional plan over the years, and they're trying to find ways to make it better, to fine-tune that, and they did that to the best that they could, and along comes this pandemic. And then there was a need that wasn't met by the traditional system, right? There was a disconnect. So that became very striking to me and other DPC docs across the country when that happened. And so then the need was filled, maybe by divine intervention, like you said, with the model. Okay, thank you for that. So, Dr. Porter, how did this relationship start from your perspective? How did Texas Disposal System come on your radar, and what did it look like for you to help them to be there when they needed you?
Well, you know, a series of fortunate circumstances. You know, I was reading your mind, Janice, so I said, this is time to send an email. You know, sometimes it's, you know, it does come from above, and just some things come together and the opportunity arises. But I had started my clinic in October of 2019, sort of a joke that, you know, COVID really, I needed to get something to happen to get my business to grow, so I started COVID. They're just going to feed a whole lot of conspiracy theories pretty quickly. COVID, you know, sort of accentuates the benefits of direct primary care. I don't want to talk just about COVID, but it's just a way of, you know, it magnifies the benefit of what we're doing. And, you know, when I set up my practice, I was leaving I'd worked for the man in a variety of ways. Corporate medicine, urgent care, I'd worked for county medicine as well. And the structures of them were just so difficult to work in because they're designed, their algorithms go faster and meeting spreadsheets and data points rather than actually taking care of the patients and actually the healthcare provider themselves being able to do it. We're all just forced into these horrible systems. So left in direct primary care. David's actually suggestion gave me the idea of the model. Well, now I'm an entrepreneur. Now I'm in business. Not quite the size of Texas Disposal Systems. That's a heck of an organization. 1,200. I got 5. But starting that out, I had to go out and network, go find people, and actually at Texas Public Policy Foundation, I met some people at TDS and chatted with them, and that's how I eventually came to know who was in the organization. Just as things were developing during COVID, one reason I was able to do a lot in COVID, we're not, you know, stuck in the algorithms that are required from insurance system. A lot of it comes from Medicare and Medicaid system, just kind of filters down, and everyone else adopts that. Outpatient medicine wasn't really emphasized. Everyone's focusing on the extremely ill, which is, you know, understandable. But as outpatient care was forgot about, well, we're sitting there, what can we do things with outpatient? Now, there's a lot of controversies over ivermectin, hydroxychloroquine, a variety of other things like that. But there's a lot of other things that are not quite so controversial, things you can do looking at it. I could do it because I'm not shackled by these various systems that are just designed to generate profits and money, or RVU's a system that many governments use. So I wasn't shackled by that. I could just practice medicine. So trying to work on business, having this opportunity with COVID, when I tell you I have an opportunity with COVID, everyone absolutely believes it that I set it up. And then I'm just opening up a second clinic, so I called up some other guys and said, hey, we need to do something else. We'll call it Omicron. Don't believe that. You can see how that one had legs on the internet. Well, because I was able to do these things, just practice medicine early, then looking for other businesses, well, let me just reach out and say, hey, we can do this when other people aren't doing it, like the big corporate-run clinics are turning people away until they get sicker. And, you know, it's very easy to treat a lot of things very early, so we were able to do quite a bit. So that's actually how it just started, in just that fortuitous moment. Then, when people came and saw what we were doing during COVID, when you sit, you know, I saw I think it was a recent research article that a physician's doing everything they're supposed to do, They have, 16.8 minutes to do everything of documentation. They only have 15 minutes to see a patient, which means, physicians are doing paperwork afterwards. I wasn't bound by that. I could spend half an hour, 45 minutes going through things and actually treating people. Then, just the value shows itself. A lot of places have to have this whole billing system, which gets so convoluted. Physicians looking at ICD-10 codes and how to maximize billing and so forth. I don't have a billing department. I don't have 5 people somewhere offshore trying to figure out all the billing cycles and all the rest of it. All that's gone. I don't have to worry about that. So we could just simply practice medicine, and then the value shows itself.
Beautiful. Okay, so you provided affordable access. It looks like from what Janice was talking about that when she mentioned this kind of disconnect, she described that, you filled that gap. You provided the affordable access. So, Dr. Porter, what are some other things that a direct primary care doc or a direct care doc can offer to an employer?
Well, generally people say, what kind of medicine do you do? Well, good old-fashioned medicine. We do, a little bit of everything. It's general practice. I also explicitly tell people I do urgent care, because how many people who are not involved in direct primary care, who have a regular clinic, would call up a regular primary care doctor because someone has strep throat or the flu, because the flu season's raging right now. He says, no, it takes me 2 to 3 days to get in. I have to go to an urgent care. And people think that's separate. You don't see a primary care doctor for urgent care. Well, of course you do. Urgent care physicians are just board certified in the same training as anyone else in primary care. They just can't do it because of the system. Well, I can do all that. So we can do anything any other urgent care or primary care doctor can do, in fact, more, and we can do it in a timely way because we set it up so we're not too busy. So everything from general health medicine, the hypertension, diabetes, general health screening, cancer screenings, all those sorts of things, up to those urgent care type things. Now, I don't have an x-ray. That's a $70,000 to $100,000 toy. That would be great for Christmas parties, but it doesn't justify the volume. And I can get a cash price. I can get x-rays for $50, $60 throughout Austin. And you do the same here in San Antonio. So we can do that whole, which is 90% of medicine. Now, that other 10% now we have, we want to make certain we have the hospitals and the specialists and other things like that. But we're taking care of all that stuff up front in a timely way. And to Janice's point about when the employee has to go to a clinic, they're losing money. Well, how much of things can be actually handled by telemedicine? Well, if someone has known allergies or hypertension, they need refills, they can text us and we'll just text them back and take care of things. Oh, your allergies are flaring again, here's what our plan is, let's do that. And that can be done on the phone or a text or an email without a visit, and they can do that actually from the truck when they're stopped and they're not driving. Then, actually, the other aspect, which is very important, a lot of numbers show this, to all you specialists out there, sorry, I don't do as many referrals as other guys because I can take care of half the things myself. So a case of a lady who's in her mid-30s came in with heart palpitations. Well, how does a primary care deal with that? Take your copay, refer to cardiology. Next patient. Boy, that was a quick one. And whatever that copay is, what, $10, $20, $50, $150, whatever it may be. Well, let's sit down and chat for a while, find out what medication she's been on, what's her family history. Do other people have heart disease early at their age? Well, let's run a quick EKG to see if it's something she was actually born with an electric conduction error, which can occur. Well, Parkinson-like is what we were thinking of. The EKG wasn't there, but how much does an EKG cost me to do? What does an EKG cost you at a regular corporate clinic or somewhere else? They'll charge $50, $150 just to run an EKG. Well, it cost me half a cent in paper and electrons, right? It doesn't cost anything to do. So we did all that and saw there's nothing there. Then we went through her lifestyle. Well, she's a real estate agent. She's drinking 5 to 6 or 7 espresso a day. She has a caffeine sensitivity. So no cardiologists who are out there. No cardiology referral in this case. And the numbers show this in many other studies, and many other clinics have shown this. And Roger, some of your data probably shows this as well. Half the referrals. So now you're saving everyone money down the road, saving time, saving money, and there's a lot of middlemen are out of it, but sorry, middlemen.
So thank you. What he's describing is saving a lot of downstream cost in the healthcare system.
One other point there on the telemedicine, some people do telemedicine almost like structured inpatient visit. Well, our telemedicine is example of cough. Well, you have a cough. Is it allergies? Is it just residual from having a recent flu or something else like that? Or is someone have a fever and a cough? No. We start with a telemedicine. Let's finish with coming into the patient. Let's have a listen to the lung and see if it's something more different. So you can use the whole spectrum of care.
So we in the DPC community are having a little hard time communicating to the rest of the world that the value of our position, because we're in a position to eliminate a lot of those downstream costs, which in the traditional system are employers are used to looking at retrospective claims data, right? But we can actually prevent that data from showing up. So we're going to figure out a way to show that value in the DPC community. But Dr. Porter, another thing that I think you failed to mention is, do you have discount lab pricing and imaging that you can pass on to employers through this direct care relationship?
Funny you should ask. Yeah. Well, it's quite remarkable. I have a contract with LabCorp, as many other direct primary cares do. They use Quest, CPL. There's a variety of different labs out there. LabCorp just happens to be convenient where I am in my locations. And I guarantee LabCorp payment. So LabCorp doesn't have to fight with insurance or chase down patients or other billing and all the rest of it. So they just give me the wholesale cost. So cholesterol check is $2.50. Some other places will charge 30, 40, 50, 60, or even more. Now, I have prior Army service, so I have Army TRICARE, and I was getting a simple cholesterol check and something called lipoprotein A, genetic risk factors. TRICARE, which is run by Humana, charged me $11.50 a copay for these two tests, lipids and lipoprotein A. It's $11.50, okay, that's not bad. Then I saw the bill, the invoice of what LabCorp had sent to Humana TRICARE. It was $220. I said, oh, then they fight over it and what's actually paid. Well, my wholesale cost for both those tests was $10. So it was $1.50. I paid $1.50 too much. That's half a cappuccino.
Okay.
So look at things.
Okay. So we've kind of alluded to another question that I want to ask. So Texas Disposal Systems is a large employer with folks in many locations around the state. And direct primary care practices are usually small, 1 or 2 docs or small clinics here and there. So how can an employer with a lot of folks or an employer with folks scattered out in different locations take advantage of that? Can you talk to that, Dr. Porter and Janice, a little bit?
Well, real quick, there's 2,000 direct primary care clinics across the nation now or more. And they can actually create the opportunities for employers to actually let their employees choose the direct primary care they want to go to. And then you just create an affiliation, as Roger and I are going to do, is so that people from San Antonio who move up to Austin, I can see those patients, and then the reverse. And then we don't have to develop a complex system with hierarchies or a pyramid of bureaucracies checking each other. We just take care of people, and we just make that arrangement, and the hub of it is the first primary clinic or maybe the company itself just managing it. It makes it very simple. Patients, the employees, patients choose where they go, find the direct primary care they like. I have a PA in Buda who's doing a lot of the work for us, and she's really very experienced. Some of the women want to go chat with the women, and then the guys come see me when their wife makes them.
Is the employer going to have to pay all of those different direct primary care docs around the state, or how is that going to work?
Well, it's quite often just goes through the one direct primary care clinic, and then they develop affiliations with other direct primary care clinics. So the employer doesn't necessarily have to take on administrative burden. That one clinic can take care of that. If it gets larger, then sometimes you have an administrative person to help with that. But it's not a large administrative burden to create that type of network, and you can take care of a large, diverse region. Perfect,
thank you. So a couple of questions back to the employers now. What was it that kind of piqued your interest about this, this concept that could fill the gap between accessible, affordable care and taking care of your people? So what were some of the barriers that you saw that you might have to overcome, and how did you do that?
Some of the needs that we had, the demographics in our organization are very diverse. And we have a number of challenges that we work through on a regular basis, whether it's about benefits or pay or anything else. We have individuals that are non-English speakers. We have individuals that are not literate, English or Spanish. And some of those individuals are not that old. They've gone through whatever system it was, and they've been passed along. And sometimes I'm a little surprised at how young some of these individuals are that cannot read. So if we send out information and we're trying to educate them, they don't always get the information they need. So some of the challenges that we had were effective communication. And so as I've been doing this for a long time, and you know, what I have found is we're only as good as the information that we can get across. It doesn't matter how hard we work or how great our widget is. If we can't explain to people what it is and how it works and how it will help them, it's of no value. So our communication had to be very multifaceted. There are people that have embraced technology, terrific. And we will do blasts. We will send out links. We will direct them to our web page. And that's really slick, and it's great, and it's wonderful. But it doesn't work for everyone. So then, okay, let's put it in print. Let's mail it to their homes. Let's make sure the spouse gets it. 9 times out of 10, they'll say, my wife is the one that does this. Okay, let's get the information home, because if we hand it to them, it doesn't always get there. Let's mail it out. Let's mail it out in English and in Spanish. Let's have a call line where they can just call in. Let's have meetings that they can come and ask questions. Let's go to the safety meetings. Make sure that we have bilingual staff that can speak to them. And so we have to meet them on their terms without embarrassing anyone, without letting them feel humiliated because they can't read, they can't write. And we help them as much as we need to. And we have to overcome some expectations from upper management, from the C-suite, that expect everyone to embrace technology. You know, they need to learn how to use the, web. I said, you know what? These individuals did not grow up with computers. They have no idea how to turn it on. But they do have a smartphone most of the time because they get grandchildren pictures and son and daughter pictures. And so sometimes that works, but not always. And so, we had to make sure that we understood our employees and their needs. And we reached them where they're at instead of them coming to us for information. We have the information, that's great, but they're the ones that need the service. And I've probably not quite answered your question. But I think that was an important piece of how we have effectively rolled out this program. We had to communicate, to your point earlier, we had to communicate what the value was for them.
Perfect.
So
you had to go to their level and communicate the value. Perfect.
Absolutely.
Okay. Bill.
And I think I can add something to explain the landscape and our challenge. So, and I'm up for the challenge, but here's what I see is it's not just that the people having the ability, it's motivating. It was frustrating to me in 2021, we did biometric screening with all of our people that volunteered to go through it, and they included a vitamin D level check and it's A1C, right? And when we saw the data, and of course we didn't see individual data, we saw aggregate data, a surprising number of people had the A1C marker, that they had a condition, and they were given the information, and is the vitamin D as well. And I know specifically one of our young guys who was a graduate apprentice, he can program a sophisticated machine tool. He had the data. His mother, he admitted, bought him vitamin D, but he didn't take it, and he ended up in the hospital with COVID. And, you know, so you've really got to motivate people to make a change and get their attention. And so that's why I know this year our wellness program kind of shut down the last couple of years, where we'd have meetings and education. But I know if we don't do that, we're not going to move the needle, because we need lifestyle changes, and we need them looking at the data. We can sign them up to the doctor, but they've got to go to the doctor.
So, Bill, thank you for mentioning that. You've touched a kind of a sensitive nerve for me, and it's the access part, you know, because I don't think there's anybody in here that has not experienced the traditional system where you go in and see the doc and they're banging away on their computer, because that's just their EMR is a glorified data entry system for billing. Lack of connection, doctor to patient. And so what we're passionate about in this direct care world is fashion doctor-patient relationship, okay? So with that, if that's restored, then the chances are much, much higher that bright, intelligent person, if they have a relationship with their doctor, and the doctor spends some time with them, will get them to change their lifestyle and at least take their medicine. Okay, so we're going to run out of time, I think. Maybe, yeah.
You just said, really quick, one of the groups that the entire department signed up, and this was our landscape crew. None of them speak English, but they have developed a relationship with human resources. It's taken us some time, but they trust our office. When they don't understand something, they feel very comfortable coming and asking questions and that sort of thing. So when we rolled out this program, you know, they knew that there was someone that could speak Spanish, so they could get comfortable with that. And they asked me what I thought, and I said, well, I'm going to do it. And so they took it on faith that it was a good thing, because I'm someone that they trusted. And so the entire department did it. And the feedback we've gotten is, it's like old-fashioned medicine. Their words, not Dr. Rogers, Porter's, or mine. And they can get through on the first call. I'm not familiar with the groups in San Antonio. In Austin Regional Clinic is huge. I was with them. Was very aggravating trying to get an appointment. I've got strep throat. I can't swallow. I need to see a doctor. It's Monday. We can see you on Friday. Well, I might be dead by Friday. What about after hours? We're booked. It was very frustrating. And so if it's frustrating for me, it certainly was frustrating for our employees that maybe have some language challenges and all of those things. So they have built relationships very quickly with Dr. Porter, with Suzanne Self, and they've been very, very pleased. And, you know, they're not changing. And yes, we're a large organization, but they've been able to take care of us. Dr. Porter is scaling his model based on our enrollments. And just a quick note for the success of what we've done, and I'm really, really excited about it, is we are planning an on-site clinic with Dr. Porter and his staff. And it's a couple of years down the road, but we're in the planning phases of that. And we're going to expand what we do with that. DOT screens, drug screenings, physical therapy, work comp. We've bought into this. And if it wasn't for the, and he didn't pay me to say this, but if it wasn't for the really strong relationship that we have built based on the service that we have received, we wouldn't be doing this. But we are going to be taking some people to the curb, and we're going to bring it all in-house.
Beautiful. So we've touched on some wonderful concepts here with this direct care model. It fills the gap. Primary care has been provided in a beautiful way, and lives have been touched. And workarounds, or not workarounds, but systems have been put in place, you know, with the right broker, with the right model, with the right doctors, and a company that's caring for their people and providing for their people. So you kind of answered the last question that I wanted to pose before we take some questions from the audience. So the last thing I was going to ask, you know, Dr. Porter started giving some examples of how we take care of people and how fun it is to practice direct primary care because we're not constrained by the traditional model. And any DPC doc has these wonderful stories, and we could be talking about that all night, okay? And if you're an employer or somebody, grab a DPC doc and ask them, and they'll share, and it'll be fun. But I wanted to ask the employers if they had a story that they could share about how someone's life was touched or how someone had access when they need it. You kind of touched on that already. If you have a story that you could share like that, please do. And then after that, we'll open it up for questions from the audience.
Well, I'm going to overshare a little bit. Both of my sons are over 26, so they're not included in our health program. And my elder son lives out of state in Colorado. And he was having some type of a crisis. We weren't sure what was going on. But he calls and says, "Mom, Dad, I need you." And it was a very frantic call. Within 30 minutes, I was on a plane to Colorado. And I get there, and I can't quite figure out, is this a mental health thing? Is it a medical thing? What is it? And he was on Obamacare. Lovely program. Couldn't find doctors or anyone that was either accepting patients or would accept his insurance. He had already been in the emergency room, and they said, "Nothing's wrong with you." Clearly something was wrong. And so I said, "You know what? We're going back to Texas. We're going to Austin. You're going to go see my doctor." And that's, you know, there is nothing more important to me than my family and my children. And if y'all are parents, you know what that means. And I had no qualms. I didn't even hesitate to text Dr. Porter, "This is what's going on. These are the symptoms." He says, "Well, there's some medical possibilities. We need to," I said, "I'm going to be there. Can you see him?" And we got back Friday, on a Friday morning at 5 in the morning, and he was already being seen, EKGs, that sort of thing, in the office, Friday lunchtime. And I share that because that is how much I believe in the program. That's how much I believe in the quality of care that, and this is our first year relationship. It's like we've been dating. And my husband is here, but he knows Dr. Porter. But that is how strong of a relationship we have built because of the quality of care. That I'm entrusting my most prized possessions, if you will, to this gentleman. And so and that's not because it's me, the HR director. That's because he and his team have treated everyone that way. The owner of our company, extremely particular. I'm sure there are no other owners like that. Ours is. And through this COVID situation, and family had COVID, and he came to tell me, I like this doctor. And then I come to find out that you spent an entire Saturday with him on the game ranch. Yeah.
Texas Disposal System has a wonderful game ranch. If you're ever up in Austin, you see those big trucks with all the animals on them. Those are the real ones. It's a wonderful thing.
Yeah, I get to see giraffes at work. Yeah, that's cool. And so that is how entrenched and how quickly it's happened. And it's about all of you that are so invested in your roles as medical providers. You keep us standing. And sometimes they'll say, well, this doctor doesn't have a good bedside manner. Well, I don't know how important that is, but genuine relationships are that important, because that's when people listen. And it's like anything else. If you have a bad meal at Chick-fil-A, you're going to tell 20 people about it. If you have a good experience, you're going to tell 20 people about it. And so don't underestimate the importance of the relationship and the bedside manner.
Thank you. Bill, do you have? Okay, so why don't we do this? Why don't we take a 5-minute break, and then we'll reconvene and take some questions from the audience.
It's good, Nancy.
Hello there. Okay, can we start to reconvene? All righty. So we've had a little bit of a break. Oh, clap. Hey there. So, all right, we've had a little bit of a break. We've had a great meeting so far. Before we take some questions from the audience, because we had some technical problems, we didn't get to give the time to our sponsors that we needed at the beginning. So we're going to give a few minutes to each of our sponsors right now, and then we'll have some questions. So Easy Access MD, who come on up here. Give you a couple of minutes to tell everybody what you do. Okay.
Thank you, Dr. Roger. Tim Randall, I'm with Easy Access MD, and you're probably wondering who we are. There's good reason for that. We're sort of new to San Antonio, but we've been around for close to 7 years now in different parts of the country. But what we do is we provide not only telehealth, but our customers really describe it as telehealth on steroids, where we also can bring some mobile diagnostics to the home of the employee. It's an employer-funded benefit. It's a per employee per month subscription that they pay, and the employees get to use the service for free as much as they need to. And that really helps to open up access to healthcare for employees, because some of those barriers of cost and also convenience, not having to go somewhere to have an x-ray, to have a strep test, or other kinds of lab tests that we can do. And for the employer, there's a lot of benefits there. It helps build your culture, for one thing, which is probably a challenge that a lot of employers have these days, being able to retain and keep good help, right? And we also can help them with lowering their healthcare costs because it doesn't generate a claim. So essentially they can get access to different diagnostics instead of going to the hospital or urgent care center. So with these capabilities, we can do about 85% of what an urgent care center can do, but we bring it right to the bedside. So that's what we do. We have some of our equipment outside if you want to take a look. learn more about it. And oh, thank you. I have slides. So at any rate, so I don't want to take up too much time because I know we're running a little bit late, but I appreciate the opportunity and to be involved with the chapter here, and looking forward to doing this even more down the future. So if you have any questions, we'll be here outside the door, and would love to talk more with you about how we can help you out. Thank you.
Excellent. Thank you. So Allison with Alti Consulting, could you come up for a minute and talk about what you do? Allison's one of our sponsors. She helps fill the gap. She's part of our FMMA community.
Hello. So we are a boutique consulting firm, and we help employers pay a fair price for healthcare, and only for the healthcare that their employees consume. As I think you know, and Dr. Porter know, that can be a huge issue. And we help small, mid-sized employers and some large employers as well. There is a little bit of art to integrating cash pay services into a health plan, so that not only the employee benefits, but the employer benefits from the savings also. So that's what we do. Thanks for having me.
Thank you for being one of our sponsors, Allison. So Family Hospital Systems, would you guys, Isaac, would you come up and talk a little bit about what you do? We're so happy to have you coming into this community and helping us with a sponsorship here.
Happy to be here. We're Family Hospital Systems. We're based in Austin, Texas, and we are part of the direct care movement. We have incorporated a membership to our hospital system that is primarily based in Austin, Texas, with plans to open a facility here in Bandera and around late February, early March. On Bandera Road, sorry. And not in Bandera, on Bandera Road. What we offer from our membership component is all-inclusive access to our emergency room, our primary care, our imaging, and our labs. We also do bundled surgical rates, and we have various different service lines that we offer in the hospital directly to the employers, but then also direct to individuals and families. My passion is working with individuals, brokers, and directly with employers to help reduce the cost of healthcare overall for everybody, and to provide easier access and better quality of care. Thanks.
Thank you. Thank you. Is there anyone here from Eagle Care Health Solutions? Okay, so that's another one of our sponsors. So we'll move on now to the last part, where we'll take some questions now from the audience for the panelist. There's a mic. Who can take a mic back there? Okay, we'll use mine.
Thank you. So as an employer that had previously considered implementing health insurance for my team at the first time earlier this year, I did look into the DPC model, but we ran into a problem with figuring out how coverage would apply for specialty prescriptions that were needed without, that would not otherwise be covered by GoodRx or any kind of programs for that. How do you approach dealing with prescription coverage without a traditional plan?
That's actually, that's always a really tough problem, particularly with new drugs like the biologics, the Humira, which actually, one reason you guys are seeing lots of ads about Humira on television these days is it's about to go generic. So they're trying to get as much as they can. But there's so many of those ones that are quite expensive, and that is one of the challenges we have. One of the other aspects about the DPC, which handles 98% of it, maybe 96, whatever it is, but the vast majority of it is using generic medications and not being influenced by whatever's on someone's particular formulary or what the PBM is, which is another story David Blott will wax on philosophic for years on. But for those small specialty ones, that becomes a real challenge because they're so new. And even the insurance companies don't like to pay for them unless they're getting a pretty big kickback. And that means, or rebates, they call it,
commissions, whatever it is, but that's drives the high cost of those particular insurance plans. So wherever you want to get those types of medications, you know, they're going to get paid somehow. So how do we do it when someone really needs it? Well, two examples recently. One's called Rybelsus, which is one of the newer diabetic medications and pills. Well, we managed to get some samples. In a small clinic, we can find to get samples and take care of that. There's a newer one, which is a dissolvable migraine tablet called Nurtec. And we're actually going to get samples from that in a little bit so we can handle those small cases. Now, those are the, you know, when we're trying to take care of them, a small group of population, that's quite often sometimes the best we can do. Now, if someone does have very expensive medications they require, then perhaps that individual, you just simply subsidize them on an ACA plan. So what I'm doing with my small crew, I'm giving you kind of third-hand advice because I still have Army TRICARE. Thanks, taxpayers. But so I offer Sedera, which is a health share plan, similar to Samaritan, Christian Health Share Ministries. Some people are familiar with. They're not insurance. There's some parallels with it, but they don't use those terms because they're not insurance and those are legal terms. But I offer that for my employees, and two people use that. One single, and the other one a guy with his family and his 3 children. They use Sedera. And then if something major comes up that can't be covered that way, then I'll go over to a ACA plan. But the reason I don't do that ahead of time is why spend a lot of money for something that's theoretical for a 1 out of 100 or 1 out of a 50 chance? I'll just take that when it comes up, and then I'll address that. So I try and anticipate everything up front. One is offering, you know, some broker, well, that party they're having next door.
So we just ask if you take the mic that you hold it to your mouth, because our online audience, even though we can hear in the room, they won't be able to hear. So please, everybody.
Hi, so by training, I'm family medicine, but also my other passion is wound care, which is considered a specialty. One of the big needs, at least in this particular community, is good wound care, specifically for limb salvage purposes. And so we have a couple of wound care centers here, and so I've approached, you know, trying to figure out how do I do this in a direct primary care model, because really, there's a certain area right in San Antonio that's more prevalent where we're seeing these amputations. That's a multidisciplinary approach where I can do my share, but then we need other specialists that unfortunately require very expensive interventions like vascular, sometimes surgeries. And so that's where I'm kind of hitting a huge challenge, because I think in those particular cases and other conditions that have high morbidity mortality, there's still not enough specialists on board. And so I just have a question or any ideas of how we can help that particular population, because there's a huge need. Here in San Antonio, we have the highest amputation rate, a lot of it related to diabetes. And so every time I approach somebody, everybody's like, well, good luck. But also even just, you know, statewide, right? Wound care, there's not a lot. And so also having that collaboration, you know, a lot of my training came after the fact, after residency. There's not an actual, or not a lot of fellowships in that. And so even that collaboration of working within a network of direct primary where, you know, we can collaborate and share that care.
Well, there's a couple parts to that. Now, direct primary care, I can do a membership model much easier. Yours would quite often requires more fee for service. There are more specialists who are doing direct care, and they do a variety of things: endocrinologists, cardiologists, and I know, and Roger, you'll know the San Antonio market better than I. You know, I know the San Antonio or the Austin market. But employers actually give an opportunity of creating a network of employers who are looking for those specialists. If they're self-funded, then they spread that cost out amongst various groups. And some of the benefit advisors here could probably talk that far more eloquently than I can. But that gives the employers the opportunity to work with other employers. Now they can create a network that bypasses all the obstructive middlemen that are out there causing so many problems. I don't know if you guys have a talk about how it is a challenge for you guys to find specialists if you're doing a self-pay model.
Well, in our case, we're self-funded, but we offer those benefits like a standard plan. So the employee just has to get the right referral and the right care. My focus, honestly, is to try to go more upstream and control the diabetes or prevent it, so you're not doing the amputation and healing the wound. The more we can work with that, and this region has a tremendous problem with that.
I'll probably talk to you afterwards as well, if that's okay, because I started in primary care and then I grandfathered into wound care. Did wound care for 10 years at 4 different centers, 3 of them here in San Antonio. And yes, specialty here's a lot. Wound care patients particularly are very sick. A huge proportion of my patients would come in by ambulance. I'd rack up $30,000, $40,000 bill just for the ambulance to come see me, a whole day off work for the family member. It was very time consuming. But at the end of the visit, I get like $50, $75. That's all I would be charging. The hospital would be charging thousands of dollars for that same care. I just read a complaint letter from a patient that got charged $3,000 for a debridement that took about 90 seconds. The doctor got paid about $42 for Medicare. And so he was so upset because of these charges that the KCI wound vac company is getting $4,000 a month. Everybody, there's a lot of discrepancy. But if you can find someone that can do an angiogram to reperfuse that leg, get that specialty care that you need, get somebody that's out of the hospital that has an outpatient angiogram center, I bet you anything if I talk to Lisa or Charles, she'd be very excited to talk to the Kempton group, take a fair price and do that kind of thing. And then there's also other resources. There's not one single bullet to the answer to that problem, because it's the problem of getting specialists that are agreeable to take a fair payment. But, when I got on the phone after we met last week, I've met these folks, Dr. Porter today, but, Dr. Isela Vasquez, she's a chief of surgery at Southwest Hospital. She's like, oh, I'd love to take a fair cash rate for inguinal hernia. I got paid $300 to do the surgery. The patient got charged $30,000, And a lot of people think that the doctors are to blame for all these high healthcare costs. It's not us, guys. It's the pharmacy, it's the ambulance, it's everything else. And look, there are real costs to having the bricks and mortar. I get it. But I think it's partnering with key specialists, particularly ones that have surgical centers like family hospital systems, what they're doing, getting that toe amputation and saving the rest of the leg. Getting the angiogram, those kind of things, and finding the specialist and building that network, which is exactly what this is trying to do. I think that's what we can do to help save limbs. But I do want to talk to you about taking care of wounds. I love it. But they're laughing back there. I brought a few wound care toys with me with Dr. Roger when I joined on in September. So, all right.
Hello, my name is Dr. Henry Higgins. I'm one of the accidental founders of an accidental healthcare system called Family Hospital Systems. I'm blessed. I represent a whole lot of other very like-minded physicians, nurses, techs that went away from the traditional conveyor belt medicine that's practiced in most of the hospitals. We never intended to build hospitals. We never intended to build a healthcare system, but it just kind of happened. More and more people wanted a place to work with us, so we ended up doing that. I've been married for 30 years because I learned early on that I just ask my wife what she wants, and I try to make that happen. It's worked out very well. And I really approach everything that way. We, the people in this room, are striving to come up with a better way to fund healthcare. And as we go through, the direct primary care movement is very powerful. I have to ask 2 questions. Number 1, what is your vision as an employer of the perfect healthcare solution for your staff? Number 2, if you're able to actually build that, how in the world does somebody get in front of you and explain to you in such a fashion that you might even try it?
I think
from my perspective in human resources, you know, my job is to look after the employees as well as the company. And so I kind of straddle the middle. We are looking for a program that the company can afford, that's scalable, but is of good quality and value for the employees. And that also needs to be affordable. So I would love to see a program, you know, DPC is great. We're doing that on the front end, but then we have it wrapped with traditional plans that take care of the catastrophic and the specialists and prescriptions and those sorts of things. So I'd like to chip away at that by working with an open-minded broker that will help us to develop some relationships with providers that are willing to work with us and work with other employers. Pull us together. You know, it can be a win-win as long as people don't get greedy. Working with Dr. Porter, you know, he'll tell our employees, you need an MRI, we'll set it up for you. This is the least expensive option. This is your cash pay price, or you can shop around. And so it's networking like this. It's in its infancy stages. I understand that. But, you know, a dollar's made out of 100 pennies. You got to start with a penny. And this is our penny or our nickel, wherever we're at right now. You know, we need to work together doing that. And I forgot the second part of your question.
So let's imagine that microphone. If you built that system, that option, how does somebody get that in front of you for consideration? How do we explain it in such a fashion that sparks your interest enough to even try it?
Me as an employer? Okay. I would say don't try connecting with the owner of the company. You need to connect with human resources. If anything goes to the owner of our company, either doesn't pay attention to it, or maybe if he makes time, he'll send it to me. Here, Janice. It's your HR departments typically that they're the ones that are vetting options. They're the ones that analyze the claims information every month. They're the ones that hear from the employees. They have the pulse of the organization. And so when our owner wanted something, he says, Janice, make this happen. He didn't say, go to Dr. Porter. And so it's the human resource director that is going to pull that information together, vet it, evaluate it, decide if it's a good option that they want to consider, and evaluate the merits of that and how it can meet the needs of their population. And so I think you just got to put the information out there. I have lots of people that want to sell me things, and sometimes I say, no, I'm sorry, she's not in. Can I take a message? But, you know, I would send out the information. I would try to make alliances. SHRM, the Society for Human Resources Management, connect with them, ask to be a guest speaker, sponsor a luncheon. You're going to be in front of all the HR professionals. They're going to carry that. They're going to be benefit professionals. They're going to be the heads of the departments. That's who you need to hit up.
So to add to that, so what I would dream, what we need is one of the big barriers is more DPC clinics around the city. So like in my case, our employees are spread out a little bit. So that's a barrier for them, candidly. So the more this idea catches on and the more clinics we have, we can get more critical mass. And so how do we get more employers on board? I think case studies, successful state case studies, and then getting in front of the employers. And there's different channels. Being an owner, I'm more hands-on and involved in driving these initiatives at my company. But there's trade associations where they have luncheons and presenting success stories. I think hearing from employers that have been in experiencing that positive success, and it's still a new concept in this region, but we all benefit if we can get that critical mass and create the transparency of the cost and the system and controlling those costs and get the money flowing to the providers, not to all the middlemen. That's the goal.
I can make one last comment. Bill mentioned trade associations. I mentioned SHRM. Y'all can get together and decide that you want to put together a benefit conference and talk about the different topics that are important to employers and invite employers. There was a mid-management benefit conference. I'm sure I'm butchering the name. Excellent conference. I'd been to it for several years, and then COVID happened and it disbanded. I missed that conference because it was real information from pharmacists, from doctors, from different groups on how to manage your benefit plans and how to understand them from the employer's perspective. There's not a whole lot of that information out there. There's a lot of salespeople, but there's not a lot of just good information. So get together, put together a benefits conference and take it on the road, even if it's, once a year. Then things like this, I got invited to this because I spoke in Austin and I was asked, will you come to San Antonio? Sure, I'll come to San Antonio. Well, our director of marketing heard what I was doing and said, I registered you for the National Waste Expo conference. So I'm probably going to take Dr. Porter with me, and we're going to speak about affordable health care and what our journey has been. You didn't know about that. We're going to Vegas in the spring. And we'll take you, darling. But that has thousands of attendees from across the country. And it is everything from Cummings and Peterbilt to employers to lots of other types of industries that cut across waste companies. And it is a huge, huge conference. And I don't know what we're going to talk about. We're going to practice our song and dance routine. But but we're going to talk about what we're doing as an employer to address affordable health care. So those types of opportunities get the word out. And employers hear that and say, how did you do that? I need to do that. Or I can't afford to continue the traditional healthcare model for our employees, but I need to do something. And that's where the communication is shared.
What occurs to me is I think we have to organize regionally and to have that critical mass of resources. And what also occurs to me is there's a lot of people making a lot of money off the current system. There's like 12 billionaires made in the pharmaceutical industry in the last 2 years during COVID. There's a lot of people that are going to fight this. That's the reality, and they're more organized. That's what we're up against.
Hanson. I do business development for family hospital systems as well. And so being on this side of it, right, being the person that's out in the marketplace, communicating to people and providers about what you guys are doing, transparency is obviously the most important, right? So just as a provider, I was just wondering what your opinion is in terms of the robustness that you're able to provide, right? In terms of the care that you're able to provide. What are like the biggest gaps still currently that you think need to be addressed and filled to make this as robust as possible?
In terms of my capability, the robustness is actually quite tremendous. The only thing that I don't have that any urgent care or any other clinic has is X-ray. But again, I mentioned I can get that easily. If I lived in a place that was more remote, okay, maybe I'd have to get an X-ray and do something like that. But that's more a low-density population area. Other than that, because I can adapt pretty much any way I need to without the cumbersomeness of the algorithm of an insurance or Medicare, Medicaid system. My adaptability makes me far more robust than the other ones. The area that of course I don't do, I make jokes about. I watch Dr. House and Young Frankenstein, but I still don't do brain surgery. And the specialty care, the catastrophic cares we're talking about, those sorts of things sometimes is where I'm lacking. Now, the comment about doing it regionally, I mean, Roger and I are talking about that in terms of affiliates between various DPCs as they grow. If there's an area where there's not a DPC clinic for such and such a business, it really only takes a couple hundred patients with membership. You can actually start a clinic, and you can start one within just a couple months. Whereas a larger clinic, a large corporate clinic, they're planning that thing out 2 years. I actually looked at setting up my own urgent care clinic about 4 years ago, and it'd be $1 million in about 2 years before I'd get payback. So because of all the structures, having to negotiate with insurance just seemed so cumbersome, it actually limited my capabilities. So the robustness, I can do minor emergencies in my clinic that a large or corporate clinic like Austin Regional Clinic, they would never do there because it takes too much time and it prevents them from the algorithm that they're on. So one thing, Janice and I were talking about is what can we do with an on-site clinic, with physical therapy, with DOT physicals, pre-employment physicals, things like that. We're not based on how is this going to be compensated by how the physical therapist is going to be billing. Since we get paid on membership, all that other stuff is, the billing issues are all taken off the table, and we can just design something that fits what the unique needs are for Texas disposal system. So it's quite adaptable and quite robust. I don't have a biologic. I don't have some sterilized garbage cans in the back to make biologic medicines, however.
Thank you. So there are no more questions. We'll go ahead and wrap up the evening. Oh, there's one more. Sorry. No, we're good. Okay. So I want to just summarize. We've had some wonderful concepts presented tonight. Direct care. I mean, I think doctors have learned from listening to employers, and employers have learned how they can put in place affordable access to care. I want to, from the bottom of my heart, thank Janice and Bill and Dr. Porter for coming and being part of the panel and taking these questions. And I want to thank everybody here for coming and supporting this community that we're trying to build to create affordable access to healthcare in this area. So with that, we'll go ahead and wrap up. Feel free to hang around and network and talk a little more. One more thing. So where do we go from here? I mean, a lot of good information was presented. Part of the thing that happens here, hopefully, is networking, and that's why we had these different colored nameplates. Name badges, so you can see who's an employer, who's a doc, who's in the middle being like a broker. So that's part of the value of getting together here. So you can talk to people and network and find solutions together that are going to fit for your situation. So that's part of the value here. A next step, I hope that you'll, if you haven't already, sign up to be part of our San Antonio FMMA chapter. We have a newsletter. So stay in touch with us, connect with us, and help us grow this. if you can, become a sponsor, bring other people here, talk about what we're doing, and get involved with us, and bring other specialists, bring other resources to the community so we can grow this and keep this momentum going. Okay, so those are some next steps. I love the suggestions. So we'll have more meetings and take it to the next level. Okay, so thank you everyone for coming.